My name's Karl Mercieca. I'm the Director of Glaucoma Services at the University of Bonn in Germany. You want to be able to offer patients everything possible and tailor-make it to that patient. So I really wanted to get the canaloplasty aspects of MIGS into the hospital. It's minimally invasive glaucoma surgery. Safe, absolutely no foreign body in the eye. Of course, you need some effectiveness. And it also makes a lot of sense from an anatomical and physiological point of view, because you're actually using the anatomy into your favor rather than creating a new anatomy, if you want. So if you have someone who's really early in a glaucoma process, then you don't want to start destroying tissue. You want to rejuvenate it or restore it. So I think it makes absolute sense trying to deal with a condition early on. If you have a procedure that's minimally invasive, will maybe sort the problem out forever. And if not, it's buying time until they need another operation. That's fantastic. So I think that is where it fits. It really, really makes sense. Nowadays, start thinking maybe you combine it with another additional part of MIGS to give it a little bit more strength. So you can then start using it for maybe a little bit more advanced glaucoma. I'm not saying the really advanced, but I'm saying proper glaucoma, not just your ocular hypertensive on one drop. And you've got these patients who have their cataract, needs to come out. It's a shame if you don't do something extra whilst you're in the eye, if they are on drops, if they have early glaucoma. What's really good about canaloplasty is you're not destroying any tissue at all. So if I need to do even like something like a deep sclerectomy in the future, the Schlemm's canal hopefully is even in a little bit better shape when I'm actually accessing it. So that's really key. I think one of the advantages of any MIGS, but particularly canaloplasty, is safety. The risk of damaging tissue is minimal. The concept of having a foreign body in the eye doesn't go down well with many people. So I have patients who come to me and say specifically, I do not want a stent. People write to you and say, I'd like this procedure or that procedure. It's incredible. Nowadays, people are really informed. They look you up, they know exactly what you've done, what you've published. Cutting destroys tissue. Cutting induces inflammation, it induces scarring. My personal experience is that when you cut, you've got two problems. The sort of immediate problem is bleeding, which also means poor vision for a few days for patients, which they don't like. The second is longer term. Those cuts will scar, and then you suddenly get a pressure spike, or you get you need more surgery. One of the advantages is you're telling them it's minimally invasive and your vision is not going to be blurred for weeks like after a trabeculectomy. If you give them a hyphema because you've cut through their trabecular meshwork and the next day they're hardly seeing a hand moving, it's not great. It's the patient experience, the patient expectation. And I'm not saying you do stuff just for the patient experience. We want to heal them from their disease, but it's hand in hand. And then it's trust. You want them to trust you because if they really need then a bigger operation, you want them to say yes to it because they need it. So trust is so crucial. So getting the right patient, anatomy, open angle, relatively early disease, and of course, as always, surgeon aspects. You don't need a phenomenal surgeon to do it properly, but getting training from the trainers, maybe visiting people who do it regularly to get the tips and tricks, going to conferences, coming to booth talks, watching an interview. Really getting the technique right is so crucial. It's ergonomic. It's relatively easy to use. We are used to having injector devices. It's kind of quite natural for us. The second thing is the ability to actually see where you are. So I find the fact that you can see that red light showing you exactly that you're in the right place makes a big difference to just not knowing and maybe pretending you do know where you are. The final and really key point is if you truly believe in canaloplasty, that you're actually just doing a canaloplasty, you want to expand those tissues. And you don't know exactly how much volume you need. So the fact that you can actually control how much volume and inject as you go in and go out makes a big difference. In the past, people would be hesitant to try a device that maybe was not as ergonomic. As soon as you start making things easier, then people will start shifting to adopt it. you are incising trabecular meshwork, you will get some reflux. But actually, compared to other devices, it's much less. Probably because we inject a lot of viscoelastic in, so which keeps it formed. There are tips and tricks as well, like, for example, hydrating the wounds at the end of surgery, keeping the pressure high so you don't get any reflux, making sure you remove any heme at the end of the operation, giving, for example, steroid at the end of the surgery. I find it's really, really important to reduce the inflammatory response.